Now, today we are going to see a case of pneumoperitonium. Before that, we see the history of the patient. The patient was a 23 years old person who had sudden onset of abdominal pain and vomiting. So he was having fever which was going on for last 15 days. It was a high grade continuous fever. And after about 15 days, he complained of that there was pain and he started having vomiting. On inquiry, he also reported that I have absolute constipation. On examination, there were signs of palpitism. The patient had guarding and rigidity. There was a rebound tenderness. The bowel sounds were diminished. He was hypotensive. Pulse rate was 120 per minute. It was weak, and the bowel sound, as already mentioned, they were absent. Now look at the X-ray picture of this patient. This shows free gas under the right diaphragm. And if you see carefully, there are some air fluid levels as well. One is present in the left hypochondrium that may, under the left diaphragm, that may normally be seen in the stomach. But there is one, it's seen right in the center, which is just at the bottom end of this arrow. So the patient has an air fluid level in an abnormal place as well. So what does this patient have right now? The anatomical diagnosis of this patient is that this patient has pneumoperitonium. Now, pneumoperitonium means there is free air in the peritoneum. Now, what is the etiological or possible diagnosis of this patient? The anatomical diagnosis being pneumoperitonium on the background of high-grade fever going on for the last 15 days and the development of these features, it suggests that the patient possibly has intestinal perforation, which is secondary to enteric fever. The third week in the enteric fever is the week of complications, and one of the complications is intestinal perforation in the distal part of the small gut, usually in the distal part of the ileum. Now, what are the differentials of pneumoperitonium? Perforation may be secondary to tuberculosis, maybe inflammatory bowel disease like Crohn's disease or ulcerative colitis. Patients who got peptic ulcer disease, duodenal ulcer can perforate, similarly gastric ulcer can perforate. Diverticular disease in older patients can have perforation when there is diverticulitis. Fallopian tube disorders, appendicitis, Meckel's diverticulum, and sometimes in patients who got acute cholecystitis, that can also perforate and cause peritonitis. Malignancy, non-steroidal anti-inflammatory drug use, injuries, blunt trauma, and penetrating trauma, both can result in intestinal perforation. And then finally, ischemic bowel can perforate. So these are different reasons of perforation because of various type of diseases. Then similarly, you can have perforation or pneumoperitonium because of certain procedures as well. For example, secondary surgical or medical procedures. Some surgical procedure, for example, if a laparoscopic procedure has been done, the patient may have some pneumoperitoneum, but this generally resolves in 24 hours to 48 hours time because laparoscopy is not possible without insufflating the peritoneum. Similarly, you can have the diagnostic and therapeutic laparoscopy, diagnostic or therapeutic GI endoscopic procedures can result in perforation, and sometimes there may not be perforation, but there may be pneumoperitoneum. For example, patients who are being placed with a endoscopic gastrostomy, so they can have pneumothorax. And then gynecological, diagnostic, or therapeutic procedures may cause insufflation of air into the peritoneum, so this may result in pneumoperitoneum. So the pneumoperitoneum can be a result of disease processes or certain diagnostic or therapeutic processes. Now, what are the clinical features when patient presents with perforation? The features of original disease may be present before the perforation develops. For example, patient may have features of appendicitis, or there may be features of enteric fever going on. There may be features of disease like peptic ulcer disease. There is diffuse abdominal pain. Initially, the pain is localized to the affected organ, and then when there is peritonitis, perforation, this spreads to whole abdomen. The patient may have diffuse abdominal pain. There may be vomiting. Patient may have absolute constipation. Patient will not be able to pass stools or even gas. There is abdominal distension, and when you do the physical examination, you may find abnormalities in the vitals. Patient may have tachycardia and hypotension. In the early part, you should look for the presence of orthostatic tachycardia and orthostatic hypotension, but ultimately patient develops supine tachycardia and supine hypotension as well, and there may be temperature. There may be abdominal distension, which is usually gaseous, and when we do a percussion note, we find that this is tympanic. There is generalized tenderness with guarding and rigidity. It's a board-like abdomen. There is reduced hepatic dullness. When you percuss over the liver area, you find that the hepatic percussion node has decreased in size. So this is a very strong sign that air is present under the diaphragm and the percussion span of the liver is reduced. There may be tenderness on percussion. The vowel sound may be absent, which differentiates it from patients who got hyperactive bowel obstruction. In the patients who got mechanical obstruction, in the early part, the vowel sounds may be exaggerated, but in perforation, since there is peritonitis, the vowel sound they disappear. Investigation labs are important. We need complete blood count to see for the presence of leukocytosis. See the ESR. If it is very high, it may indicate chronic inflammatory disorders. Go for blood culture, and if possible, aspirate the peritoneal fluid and send it for culture. And there may be culture required in other conditions. For example, in enteric fever, you may even require bone marrow culture. So appropriate cultures may be taken. Go for the renal function testing. Test for the serum electrolytes, because hypokalemia is one of the conditions which can mimic intestinal obstruction causing paralytic ileus. Check the blood sugar, check the liver function test, check the ANCA and ASCA to see the presence of inflammatory bowel disease or vasculitis. Then gamma interferon may be tested for the presence of tuberculosis. And then finally, you may go for lactic acidosis. That may be high in patients who got ischemic gut. So these are the lab investigations. And then important investigations are the imagings. What images we require? The most important in the preliminary investigation is the plain X-ray of the abdomen in standing position. This shows us there is free gas under the diaphragm. In the right rim of the diaphragm, over the liver, you find a crescentic shaped black shadow, that is free air in the peritoneum. Then you may go for an ultrasound of abdomen. This may indicate that there is some peritoneal fluid present. The ultrasound may not be very much helpful in the diagnosis of intestinal perforation. The plain X-ray definitely is the investigation of choice. And then we can go for a CT scan of the abdomen with contrast. CT scan of the abdomen shows intraperitoneal fluid. There may be bowel wall discontinuity, may be seen in cases of perforation. There is extraluminal air and there is extraluminal contrast. The contrast leaks into the peritoneum and you will find extraluminal contrast. So these are the investigations which are required to confirm the diagnosis of intestinal perforation, but generally the clinical picture and the plain X-ray tells us that this is intestinal perforation. Then treatment, we go for medical treatment. Medical treatment is just supportive. Keep the patient nothing per orum. Keep record of intake and output. Fluid management is the most important part of this treatment. Fluid resuscitation and correction of any electrolyte abnormality if it is present. So go for the fluid resuscitation and electrolyte correction. And then broad spectrum antibiotics, which cover gram-negative anaerobic organism and gram-positive organism. So we require broad spectrum antibiotics to control the sepsis. And then definitive treatment is surgical. Surgical treatment is exploratory laparotomy, and we treat according to what is the cause. So we identify what's and where is the lesion, and we treat it accordingly. May it be a primary repair, or we may go for an ileostomy or a colostomy with a secondary closure, but in some cases we may go straight away for a primary closure, for example, as in peptic surgeries. The complications are intra-abdominal abscess and generalized sepsis syndrome. So these are the complications of intestinal perforation. So this is all about intestinal perforation in brief.